This program is a presentation of UCTV for educational and non-commercial use only.
Let me now introduce our next speaker, Jackie Leong. Jackie is an anesthesiologist. She's a professor of anesthesiology, and she was one of the early folks that were interested in this whole area of postoperative cognitive dysfunction and postoperative delirium. And she has an outcomes-based research effort, and she's studying the risk factors for these altered cognitive states postoperatively, and she's going to present some of her data.
Thank you. Before I begin, I just want to thank all the speakers for their participation, and also to thank one of our lead administrators, Tula Gordon, for organizing this. Her attention to details really made this success. So thank you, Tula. Appreciate it. In the interest of time, I might actually skip through some of the slides, so to give Christine plenty of time for her topics. One thing I do want to clarify is that we haven't really talked about definitions, and there are a couple of really distinctions here. First of all, we've talked about postoperative delirium a little bit, and I think the audience who takes care of patients know that this is really acute confusional state with alterations in attention and consciousness. And this is a recognized, entity. We actually bill it, ICD-9, ICD-10. Whereas POCD, postoperative cognitive dysfunction or decline, is really a decline in a variety of neuropsychological domains. And Dr. Kramer talked about that. And we don't really know if POCD is the same as postoperative delirium or is it an extension. And I hope that we can get to that a little bit, perhaps in the question and answer. So the question is, on a Venn diagram, are they something like this? Are they intercepting with each other? Do we see some patients with delirium and POCD? Do we see some with delirium or, and others? And I think the problem with answering this question is that if you read the literature, a lot of the delirium studies are done by geriatricians, certainly in the neurology literature. And POCD has been really done recently by really a lot of folks in anesthesia. And most of the studies you see in the literature examine patients about a week after surgery. And as we know, delirium after surgery occurs soon after. So there's been very few groups that look at them simultaneously. And our group started this effort about 10 years ago, and we were interested initially in the effect of anesthesia on cognition. So we perform neurocognitive testing soon after surgery, day 1, day 2, day 3. We also do delirium assessment at the same time using standardized measures of measuring delirium. And Laura Sand's been a major collaborator in this effort. What we found was that in a cohort of older patients coming to surgery at UCSF, and these are 65 years of age or older, coming for major surgery requiring anesthesia, non-cardiac surgery. And we took the group who were not delirious, and we found that, in fact, if you perform neurocognitive testing on them, 15% of them developed POCD on either day 1 or 2. So patients who are not delirious can also exhibit features of POCD. So I think that maybe we're looking at a phenomenon such as this, that we see the acute delirium, and if we don't do POCD testing, we wouldn't know, but could POCD be a subsyndromal type of delirium as we go further out from surgery? That's one of the questions. So I need to talk a little bit about delirium because I really don't think the two can be totally separated. The question is, how often do you see postoperative delirium? And by using DSM-3 or 4 measurements or the confusion assessment method, you can see the incidence vary widely throughout the literature. The highest incidence certainly found in emergency hip fracture surgery, as high as 40%. In aortic surgery, vascular surgery, it could be as high as 50%. The yellow is our own work in the same cohort. Almost 1 out of 2 patients developed delirium on the first few postoperative days. And initially, I was questioning our data. Why is it so high? And in fact, when we looked at our patient who had delirium, in fact, the length of stay was 4 times of those who didn't have delirium. So I think we are seeing a group that was at very high risk. And we use very sensitive measures. As most of you know, delirium is important because it prolongs your hospitalization. so it costs money. Further functional decline, cognitive status decline, increased institutionalization and mortality. A few weeks ago, I went to see a patient with my research assistants because he was in one of our research studies, clinical trial. And he was in the ICU postoperatively. After discharge from the ICU, he continued to be delirious. And I went to see him, and his wife was convinced that he was giving a drug, a toxic drug, that caused him to be delirious. And in fact, if you look at the literature, to find identifiable causes of postoperative delirium, you actually would usually not find an etiology. So a study published in the 2000 found that only about 7% of patients were actually assigned its definitive cause that's attributed to the reason of delirium. So majority of cases actually have no single etiology despite extensive workup of these patients. So I'm going to skip this. Basically, I think many of us think that delirium is a geriatric syndrome, that you have vulnerable patients and superimposed with precipitating factors, such as age, we talked about, sensory and cognitive impairment. I'm going to skip this just because we're going to move on to the next section. And the key question is, if you review the literature, what are some of the precipitating factors from the surgery itself? And when you look at the literature, there's a few that's been outlined. In an early study by Mark Antonio, he talked about increased blood loss during surgery would increase the risk of delirium. And then type of surgery we talked about, cardiac and orthopedic. Although I should say that in recent studies, patients undergoing cardiac surgery without going on pump, they have an equal chance of having postoperative delirium or POCD. So that's kind of interesting. Typically, we think of embolic, phenomenon as the etiology. What about anesthetic factors? We listened to Dr. Z talked about the effect of isoflurane, the apoptosis. We often think that regional anesthesia, such as spinal anesthesia, will be better for a patient because they're not exposed to as many drugs, first of all, and certainly they wouldn't get the inhalational agent. But in fact, the data to date has been really not very convincing, although there are some limitations. And the two studies are Williams-Russo back in 1995 in total knee patients. One group got randomized to receive general anesthesia, and the other group got epidural anesthesia. In a European study, Rasmussen was the lead author. Non-cardiac surgery, one group got general anesthesia and the group got epidural anesthesia. And there's been really no difference in the incidence of postoperative decline or dysfunction. And in the Williams-Russo study, no difference in the incidence of postoperative delirium. Although I think both studies have limited power in the conclusion. But the evidence is not very strong that regional is more protective to the brain, if you will. So lacking a difference, what about the way we manage patients during surgery? And I think we all want to avoid having a patient be made hypotensive and have decreased cerebral perfusion. And so that question was addressed by Williams-Russo again in a different study published in Anesthesiology in 1999. She took a different set of patients for total hip replacement this time. And all the patients got epidural anesthesia, so regional anesthesia. One group had controlled hypotension, mapped down to 50. And the other group was relatively normotensive. And she did serial neurocognitive testing, and she found that there was no difference. So at least in an elderly group of patients, 65 years of age or older, going down a map to 50 for a total hip didn't seem to lead to an increased incidence of POCD. However, they did rule out patients with known carotid disease and did the Doppler. So it's a very carefully selected cohort. So the evidence is not overwhelming that hypotension have a detrimental effect. So moving away from blood pressure measurement, what about specific anesthetic agent? And when I first started doing investigation in this field, I talked to Dr. Eager, who is a giant in our department, and I asked him, I want to understand if any anesthetic would be a problem in causing postoperative delirium and or cognitive decline. And he suggested me to study nitrous oxide, which is laughing gas. Is the most commonly used anesthetic in most of the world, over 100 years at least in usage. So we did a study without going into great details. We randomized patients into receiving nitrous oxide along with other anesthetic. and another group without nitrous oxide. And we did serial neurocognitive testing, delirium measurement, and we really didn't find any difference. So it seems like nitrous oxide was not a culprit, even though there's strong animal evidence suggesting that it's neurotoxic. And so this brings us to, if we couldn't identify type of anesthesia, the way we manage patient, specific anesthetic, what about the whole period after surgery? After all, we know that patients are exposed to a lot of medications after surgery. They go through a huge hemodynamic change and pain. So our studies incorporated a separate feature that is to look at the patient's medications and pain. And so without going into great details, what we found is, interestingly, that if you take a cohort undergoing major surgery at UCSF, and you take into consideration all the covariates for postoperative delirium, including age, type of anesthesia, education level, et cetera. The things that stand out was, interestingly, again, age, but other factor would be pain, patient's preoperative pain level, and if they have worsened pain postoperatively. If you examine the cognitive status right after surgery, and the way that they were medicated for pain, the use of PCA, seems to stand out as the most important factors to elicit the occurrence of postoperative delirium. The next question that I want to ask is, what about clinical trials in the intervention of postoperative delirium? How do we stand on this? And the number of clinical trials has been really quite limited if you look at the literature so far. Rivastigmine was used in cardiac surgery, and I think it was being investigated because of case reports showing that the use of anticholinesterase inhibitor improved cases of delirium. So this study was done, a small study, placebo-controlled, 120 patients, and no difference in the incidence of postoperative delirium. And another study, separate study down at Stanford, first author was Maldonado, showed that patients who were given dexmedetomidine, which is an alpha-2 agonist, had a reduced incidence of delirium compared to patients who were sedated with propofol or midazolam. And again, the sample size is small and remains to be validated. The other studies that are sort of not as drug dependent was clearly the one that's been discussed a lot, and that's by Mark Antonio. And this was in emergency hip fracture patients. In this study, patients who had emergency hip fracture who were undergoing surgery were randomized into two groups. One group got proactive geriatric consultation versus standard care. And you can see the delirium rate here was lowered when there's geriatric consultation. So obviously, we don't know the reason why the rate was reduced, but there was a reduction. Because of our earlier finding that postoperative pain and opioid use seems to have a correlation with early onset postoperative delirium, we underwent a pilot study with a hypothesis that if you can reduce opioid use after surgery and yet supplement them with an adjuvant that provides sort of equal analgesic, if you will, pain relief, would that also lead to a reduction in delirium? And the small study that we did was surprisingly efficacious, showed that using a non-narcotic adjuvant such as gabapentin reduced the delirium rate in non-cardiac surgical patients. And so we're conducting a larger trial to validate this finding. Recently, there's another trial that was published in the Mayo Clinic. This was patients who had hip fracture surgery. All the patients had spinal anesthesia, but they were sedated with different sedation level with propofol. One group got lighter sedation as measured by this monitor called BIS, bispectral EEG, versus a more deep sedation. And they found that there was a decrease in the incidence of delirium in the light sedation group. And this is Fritz Sieber's group. And I know that the grant just got funded, so I think they're continuing this in a larger study. So in summary, with respect to postoperative delirium, I think the etiology is probably multifactorial, since we know that there's patient factors and there's precipitating factors. The anesthetic protocol to reduce delirium is not really out there. I think it needs to be studied further to understand the role of including pain management, how that's to be affected. I didn't discuss that, but certainly the evidence to date would suggest that there's some drugs that we should avoid. So the next section I want to talk about is what is the relationship between surgery and POCD? Now, my collaborator, Dr. Sands, wanted to use the term POCD to stand for post-operative cognitive decline rather than dysfunction, because she said that we really don't know what normal function is, and I think that's really true. So I think we've talked a lot about there really are currently a lot of methodologic issues with POCD measurements. We don't really have a uniform criteria of how that's actually defined. If you read the literature, the European group used a different way of definition. Terry Monk's group is slightly different, and we use a different way to define. But most use, obviously, various tests based on changes in these domains, as outlined up here. The problem is that the test selections really varies greatly. So, and I think the problem is that, as Laura has alluded to, is that we really don't have a clear, theoretically derived and empirically tested model to know the causes and outcomes. So really targeting the right domains is the question we frequently asked. So the other thing I want to talk about is that we have not talked about the timing of POCD. Surgery here is time 0, and most of the studies that measure POCD or cognitive testing is early at 1 week, intermediate will be at 3 months, and then longer term 1 to 2 years. And I think what we're looking at is as follows. We have a patient who has certain cognitive reserve, whether it's age, level of education, or other ways to assess them. Then we impose this stress of surgery, maybe anesthesia, and then we have this acute phenomenon of post-operative delirium and POCD. And the question really is, what is the relationship between this and long-term cognitive decline? I think that really is an important question as well. In terms of risk factors, for early and intermediate POCD, Dr. Mesa talked a little bit about the ISPOCD work, namely age, level of education, burden of illness, preoperative depression, preoperative cognitive impairment, and preoperative habits such as drug use. And ApoE4 has been a little bit controversial. And some studies, such as ours, show that there's a relationship between preoperative genotyping, ApoE4, and postoperative delirium. And the 2 larger studies on POCD shows that there's a lack of association. And I think it's probably maybe because of the patient population and which factors really compete with each other, which stands out more as an independent factor. So aside from these baseline patient-related factors, the next question is, what are the stressors that might precipitate POCD? And Dr. Mays talked about postoperative infection, but there are other factors that's been identified by various studies, including patients who needed to have a second operation after the initial operation, patients who have respiratory complications after surgery. Again, we said general anesthetic type has been controversial, anesthetic maintenance. And then in our studies, the way patients manage postoperatively seems to have a difference on the risk of POCD. The next big question is really, does this early POCD, the neurological changes we see a week after surgery, for example, does it lead to longer decline in cognition? That is really the hot question right now in our specialty. If you look at the data so far, if we look at that timeline again, 1 week, 3 months, and 1 to 2 years, the European data, ISPOCD, shows that about 26% of patients develop POCD if you measure it at 1 week after surgery. And only about 10% of patients have POCD at 3 months. And look at how low it goes down to at 1 to 2 years. Now, they use a control group, so it's a little bit different. It's not clear if the controls are really matched controls. Williams-Russo didn't do longer-term follow-up, but her 3-month data is about 5%. So we don't have a lot of studies with longer-term follow-up, and that's really what we're lacking. We don't really know how this goes. However, there are some recent data from other investigations, and I want to share them with you. This was an older study, and these authors basically asked the questions. Is there a risk of cognitive decline when someone's being exposed to general anesthesia? And this was a cross-sectional population study from the Netherlands. They have over 1,200 patients. Age range was 24 to 96 years of age. They found of this 1,200 patients, more than 900 had at least 1 operation under general anesthesia. what they found was that a history of an operation, the number of operations, so cumulative effect, total duration of anesthesia, was associated with subjective health complaints of the patients, but did not predict cognitive performance based on their neurocognitive testing. And so Michael Avedon, who is from St. Louis, published a paper in our journal last year, and basically follow a similar approach of the prior paper by Distra. What they did was they asked this question. Basically, are subjects already on a trajectory of decline before surgery, and we just happen to capture them? And what are the effects of surgery on cognition in patients with pre-existing cognitive dysfunction or Alzheimer's disease? So the difference of this study from a lot of prior studies is that this was a retrospective cohort, and subjects were recruited from the ADRC. But the subjects were included not because they necessarily are undergoing surgery, but they are followed. There's a lot of pre-event data, and the event is defined as anyone who subsequently underwent non-cardiac surgery, became ill, who has to go to a hospital, or have neither of them. So of this cohort, they found 575 subjects, and about half of them were not demented, and 361 had very mild or mild dementia at recruitment. And patients who underwent cardiac or carotid neurosurgery were excluded, and the median follow-up was about 3 years. What they found was that the demented group declined more markedly, and approximately a quarter of the non-demented patients progressed to a clinical dementia rating of more than 0, meaning having some cognitive impairment, but not more common after surgery or illness. And neither the demented or the mildly demented patients had accelerated long-term cognitive decline. So when this paper came out, it created a lot of controversy, clearly, because it seems to suggest that long-term cognitive decline was not related to anesthesia and surgery. And there's been a lot of letters to the editor on this. So the question that's also been raised is, what about patients with mild cognitive impairment? Does that increase the risk of POCD? So Becker and his colleague published in the Surgical Journal recently. This is, again, a retrospective cohort. Again, taking patients from community dwelling volunteers participating in the aging studies. And they were divided into whether they were normal or have mild cognitive impairment expected for a person's age without interfering with their activities of daily living. What they did was a post hoc analysis shows that those with MCI, with mild cognitive impairment, had a greater decline in performance of one of the tests, the digit span forward, compared to the normal groups. And so the question that I ask is, what is the significance of this? Does that really negate, evidence results? In Mark Antonio's group in Beth Israel, they published a paper in Neurology, and these were actually patients with Alzheimer's disease, and who subsequently underwent surgery. They look at the score, cognitive score, whether there's a change, and they found that if subjects develop post-operative delirium, this is the solid line, had an increase in score comparing those that are not delirious. So taking this next step further is, what about the long-term consequence? Mervyn had talked about POCD with increased mortality and decreased functioning. And we do know that from results, for example, from cardiac surgical patients, the cognitive status at discharge was associated with long-term cognition. So if you have a lower cognitive status at discharge, that was associated with longer term decline. And then with Monk's and Steinmetz group, they both showed that POCD was associated with increased mortality at 1 to 3 months. One group showed at 1 year, and one group at 3 months after surgery. And so I think the data seem to be a little conflicting, and I don't know whether this really is implicating a causal relationship. Are we seeing patients with POCD that are really a marker of someone with cognitive impairment or mild cognitive impairment to start with, and somehow they just really have a worsened trajectory on long-term follow-up? That's the question. I think the data to date would suggest that I think patients who have a good cognitive reserve, perhaps someone with a higher level of education, may be more protected against the stress that we've seen some of the precipitating factors during surgery. And I think when we talk about etiology of POCD, I think we need to be cautious. Are we talking about the early POCD versus later on POCD? It may be different. And I think the data from Dr. May's lab is very exciting and clearly needs clinical confirmation. I think one of the more important questions is the long-term consequence of early POCD on subsequent cognition is really unclear, and I think is an important topic. And I hope that with our collaborative work, we might begin to think of a way to tackle them. Thank you.